Good day, my dear students. How are you all reading for your exams? I know that you will be in a state of tension or anxiety. That is very natural. On my part, I shall be slow and deliberate and try to cover the salient points of applied aspects of autopsy of the heart. A nice quote whatsoever. There may be no single thing that can teach us more about life than death. We had seen the various methods of opening the heart. And if you go to Ludwig, you will be able to get the complete panel, which I have, however, produced here. This we had seen in the earlier class also. But what is important is the underlying components are the most important ones which we should bear in mind. However, when the examiner asks, we should be able to rattle off the other modes of autopsy of the heart. So this is the complete list which I would like you people to kindly memorize. If possible and probable, I would like you people to kindly follow the list that is being given. The questions can be disease-wise, in which case we shall choose rheumatic heart disease as the probable one. You find that this is a picture of the left atrium in which there is a patch-like thickening. It is an area of fibrosis caused by a jet-like impingement of the blood, or it can be an Ashoff nodule on its own, the McCallum's plaque or patch. Also, we should be bearing in mind what are all the vegetations that can be occurring in the leaflets. Various questions can be asked, which I shall summarize towards the end. These are, for example, the salient points that we will have to remember about rheumatic heart disease. And these are my paramount important sources of reference, Robbins and R.A.T.S. Vegetations. You find that the questions will be going like this. What are the vegetations? How do you find the different vegetations? How do you distinguish? So on and so forth. So I would like you people to kindly go to the undergraduate class and then revise these. Also, you find in a case of infective endocarditis, it is friable, overhanging the edges of the leaflets, sometimes causing a perforation. Whereas in a rheumatic heart disease, they are small, firm, and along the lines of closure of the valve leaflets. As it becomes fibrosed, however, you get a fish mouth or a buttonhole like stenosis, and look at the thickness of the valve leaflet and its opacity. Coming to the vasculature, there are a few questions related to the vasculature, and in this case, the disease that we will be having in mind will be myocardial infarction. This is a beautiful picture that I have downloaded, and it gives us a lot of information. Maybe we'll feel that why so much is required, but then I felt why this is not. There are two major branches, the left coronary artery and the right coronary artery. And in these two also, I used to remember the left anterior descending and the left circumflex artery. There are the others also which you people can remember. On the other side, I have got the right coronary artery, which used to be mainly a kind of a single artery, but then there is also a posterior descending and a marginal artery. So this particular things in the box alone, you people shall remember. And the opening of the coronary ostia will be exactly distal to the aortic valve. Just when the aorta comes out, these will be the ostia that will be found first. Another method of dissection, apart from the inflow, outflow, etc. This is called the short axis method. So along the short axis, both the ventricles are being cut. This is the lateral wall, interventricular septum, and the right ventricle. This is a picture of the normal heart. In this case, I find that this is thinned out. That is because of dilatation. There has been an infarct of the left ventricle, as a result of which it becomes distended. One of the complications of it. Just to show the importance of the short axis method of dissection, mainly to show the complete endometrium and the myometrium, particularly in cases of myocardial infarction. Look at this one, a picture from the web path, a superb picture, and I find that there is an infarct. So a lot of questions will be there. That is why I would say kindly go back to myocardial infarction. There can be a subendocardial infarction, there can be a transmural infarction, so on and so forth. And this is also a case of an infarct. There has been a massive hypertrophy. I call it a concentric hypertrophy. The interventricular septum, anterior wall, posterior wall, and the lateral wall are all uniformly thickened. And there has been a sudden death. So the infarct would not be identified, but when there is an application of triphenyl tetrasodium chloride, you find the normal myocardium appears red, whereas there is a pallor in the infarcted area, thanks to Robbins. This again, I would like you people to kindly go to any textbook. Robbins itself will be fine. Ludwig has given a wonderful picture, maybe Langevar also. I would like you people to kindly memorize at least a skeleton of it. What can be the changes in the myocardium? So what are the macroscopic changes? What are the microscopic changes? And what is the time taken that is for these things to manifest? Finally, you find after weeks, there will be a fibrosis wherein it becomes pale or white. The vasculature as such. One is the coronary artery we had been talking about. And then look at this one. This is the aorta. In this aorta, I am finding that there is something wrong with the intima. It is not smooth. And at the same time, I am able to see that it has been torn apart and there is a media that I can see through it. This is a classical case of a dissecting aneurysm of the aorta. Always between the esophagus and the aorta, they will ask you, how do you distinguish? I should look for the ostia of the blood vessels. Ostia of the blood vessel should be there. And this is a case of an abdominal aorta wherein there has been a fusiform aneurysm, in which I am finding deposits of, you find that the lines of Zahn could be made out. Alternate dark and light lines of a thrombus. Again, a beautiful mural thrombus. A mural thrombus is a thrombus that is found in a large capacious chamber, such as the ventricle or a distended aorta. And this is analogous to this one. So this wave, lines of Zahn, was actually distinguished and identified, beautifully described in a geographic context rather than pathology. I would like you people to kindly compare this. Superb illustrations. The source is given over here. And what are all the questions that can be asked in the blood vessel? Again, the short axis method being continued. What else can we identify? In this case, I find that the right ventricle is becoming thicker. There is a right ventricular hypertrophy. Also, I find that there is a defect in the ventricular septum, as a result of which, instead of the pulmonary artery and the aorta, there is a common ostia for both of them, which could be seen. So this is one of the uses of the short axis method of dissection. Regarding the coronary arteries, what all should we look for? Angiogram is one that could be done, or an earlier angiogram of the patient should be seen. Whether there is any calcification or an atheromatous plaque, tortuosity of the blood vessels, opening, and sometimes you find that In a case of non-cardiac lesions, longitudinal sections can be made. But if it is going to be a cardiac cause of death, I should make regular slit-like spaces at 0.5 centimeters interval so that I will be able to identify a thrombus or an embolism or both. If there is an area of calcification, that obviously should be decalcified. So this is the protocol that should be followed for examining the coronary arteries. Veins, on the contrary, are opened longitudinally. Now, what is this cross section? What is this longitudinal? We shall be seeing. And coming to the arteries, these are all the various things, arteries or even the veins to look for. Thromboembolism, atherosclerosis. If at all there is an obstruction, you are supposed to grade the obstruction. There can be an intimal tear, as you may find in the case of a dissecting aneurysm or a Marfan syndrome, any congenital anomaly. All these can be looked for. A beautiful picture. Of course, there has been a bit of a pericarditis, but the blood vessels are being superbly displayed. Sometimes you can cut them with. So this is again a wonderful instrument that is used for cutting the blood vessel, from which I can deliver a cast. A cast that has been causing an obstruction can be removed. So this is a tube with a cutting edge, and this is a caliper or a scale with which I will be able to measure the degree of obstruction or the length of the lesion. The classical bread loafing method, particularly in a case of a coronary artery, you find that there is a normal blood vessel and then it progresses to a severe obstruction. So as it progresses, you find that there is an expansion in the extra endothelial material. Extra endothelial material is getting, and there is a shrinkage in the lumen. And finally, you find that there is also a shrinkage later on, but there is a compromise in the luminal blood flow. The American Society of Cardiovascular Surgeons have graded it into grade 4 grades rather. It will be 25%, 25 to 50%, 50 to 75%, and more than 75% obstruction. And this is the classical bread loafing method. Obviously, you people will be able to understand the importance. Here it is a little distended and narrowed over here. Here it is again much more narrow. I am able to appreciate some yellow material, probably a fatty streak or so. And this is an atheromatous plaque, rather a coalition of atherosclerosis with multiple complications. Complications of atherosclerosis, you people will have to go back and read. And here again, look for the ostia of the blood vessels. Ostia of the blood vessels. Otherwise, the examiner will purposely try to pull your leg. Why can't it be an esophagus? And these are all the related topics found in R.A.T.S, my channel, and in Robbins. And these are all the things that have been covered in the R.A.T.S itself, which are pertinent to autopsy of the heart, which I would like you people to kindly go back, listen to my channel, go back to Robbins and read. And a wonderful source. And look at the edition over here. The 8th or the earlier editions is always better, whereas the later editions are more molecular, difficult to digest and reproduce. However, it is up to you people. What are the standard methods of examination? Now, the heart is fixed in formalin for a period of 5 minutes. Normally, when it is removed, you find it is covered with blood and it will be shiny, etc. In order to remove that and to create a dullness so that you can examine it properly, it is fixed in formalin for about 5 to 10 minutes. Photography is again taken. I mentioned earlier, the heart is not a structure that will collapse that easily. But even otherwise, you find it can be fixed with paraffin wax and it can be displayed also. If the death is due to non-cardiac cause, only a few bits are required. If it is due to cardiac, you will have to give multiple bits, and this will be the dimensions of the sections. Subendocardial region, arteries, conducting system of the heart, and all the other regions. This incidentally is a window method of opening. Window method wherein there is a minimal damage to it. I am cutting open the great vessels, seeing what is within, and it can be fixed with formalin so that the outline is formalin and paraffin wax so that the outline is well maintained. External abnormalities, pericarditis. So the various questions regarding pericarditis, the people can be asked. Even otherwise, what are the causes for cardiomegaly? Where do you get a boot-shaped heart, a flabby heart, pericarditis, cardiac tamponade, aneurysms, and a banana-shaped heart, etc. These are all some external abnormalities which we should have in mind. Pulmonary artery, a beautiful animated picture again from WebPath. So it shows a leg vein thrombus that is getting dislodged and going up, getting blocked at the bifurcation of the pulmonary artery. Typically what is called as a saddle embolus. And that is what we are seeing over here. Saddle embolus, and part of it can be extending into the pulmonary artery so that I see a Y-shaped structure that is obstructing. This leads to an immediate death, and it is called an agonal thrombus also. And changes of infarction may not be seen in the heart because it takes some time for all the changes of necrosis to manifest. What are we seeing over here? Sure that it's the aorta. I am able to see the multiple ostia of the blood vessels. It is the things that you least expect that hit you the hardest. Any idea what it is? And what is this, by the way? So it is another natural structure, the bark of a tree. You find that this kind of an appearance is there. So I hope you people will be able to make a diagnosis, bark of a tree appearance, classical of syphilis. Why it happens, etc. You will have to go to cardiovascular syphilis and read up. Regarding the bits. So look at a picture. Whenever I look at a picture, take some time. This is a right atrium. Lower down will be the right ventricle. In the right atrium, close to the interatrial septum, there will be an area of thickness that will be the SA node. From this, you find there will be branches going down on either side of the interventricular septum. Always, this area of thickness going lower down is taken as a rectangular bit, and then it is being processed. See what is happening over here. This is a SA node, and this is probably the AV bundle, and this is part of the ventricular septum. So it has to be given a bit like this so that we'll be able to study any abnormality if feasible. So this is a beautiful list that I had compiled by myself, and I had shown all the regions, what can be the material that can be studied, and what can be the diagnosis or the implications of those. So this is given. I would like you people to kindly spend some time and see them. In this, what is the site and what is the use of the bit. So sampling of the heart and the blood vessels is of great importance. Always, not only here, your preparation of a table or a chart will help you save time, and you will be able to be faster so that you are exposed to more questions and more marks. This again is being continued. Vegetation, aorta, etc. Nearly 17 areas I have mentioned. And for all of this, what is the significance and what people can identify? Rupture in the case of myocardial infarction, a spelling mistake over here. Site and use. So a comparison over here, sometimes we look at the ventricle from the top. Here I am able to see the normal mitral valve over here, whereas in this case the valve leaflets are bulging into the atrium, what we call as a myxomatous valve or a floppy mitral valve. It can be seen either congenitally or in a case of a Marfan syndrome. This is what people should be looking for, and I've explained it in the first session itself. There is another method of dissection called the long axis method of dissection. Long axis method of dissection means from the base of the heart to the apex of the heart. So it is being cut. It can be either on the left side or on the right side. So it is a long axis method. So this is a normal ventricle, normal atrium, aorta that I can see. Whereas in this case, I find that this is a mitral valve which is somewhat going inside. There is some abnormality with the valve, and this is the ventricle and the aorta. Maybe a floppy mitral valve or a prolapse of the mitral valve leaflet. Again, in the case of the long axis, earlier we had seen the short axis, now there is a long axis. The structures of the aorta, the left atrium, and the mitral valve over here. And this incidentally is the left ventricle. And it is bulged because of the left ventricular aneurysm, which can be secondary to a myocardial infarction. And in this one again, there is an incomplete septum, a ventricular septal defect. These can be identified and displayed when we do a long axis method of dissection. As I had been mentioning earlier, the question can be region-wise or sometimes it can be defect-wise. In this case, it is an amyloidosis. In amyloid, the heart will be enlarged, it will be pale, it will be waxy. And this is a source of reference for these pictures over here. The type of amyloid that you people can get is senile, or it can be AL amyloid secondary to infection and inflammation, TTR. These are the types you can get, or it can also occur after chemotherapy, liver transplantation. The importance of the amyloid is it causes conduction defects. It will compress upon the bundle of disc and the atrioventricular bundles that lead to compression. So this is the histological picture wherein I am able to see pale eosinophilic acellular material in between the myocardial fibers. And this can be demonstrated by means of a polarizing microscope and the apple green birefringence that you people can see in the case of Congo red stain. There is another method of section called the coronal section and sagittal section. Coronal means the antero-posterior view. You people will have to recollect a little bit of anatomical nomenclature. Antero-posterior view, this is a normal diagram that you get in any text. In this, I am able to see the great vessels as well as part of the atrium, both the ventricles, ventricular septae, etc. can be made out. And there is another view called the sagittal view. This is the lateral position in which I will be able to see both the ventricles and maybe left atrium and the aorta. Similarly, it can be the other side also, which I can see. So these are the two sections which can be used. So when you are asked about the dissection or the methods of opening the heart, I hope you people will be able to recollect and rattle off all these methods. Again, this is a longitudinal method by which it has been cut, in which I am finding that the ventricle is quite hypertrophied and it is compromising with the ventricular volume. In this case, it is not allowing the blood to flow in, something called as a restrictive cardiomyopathy. Here it is a hypertrophic cardiomyopathy. As a result of the restriction, I find that the atrium is getting distended. A beautiful picture again of it. The differential diagnosis we people should be having in mind will be hypertensive heart disease, as in a case of hypertension or valvular stenosis or incompetence. So this can be a differential diagnosis. Otherwise, usually it assumes a banana-like shape. Both the ventricular walls as well as the interventricular septae are involved. It is not only the left ventricle but also the right ventricle that is thickened in a case of cardiomyopathy. This itself is an essay question for you people, and I'm sure that you people will be reading it up. And this is a 4-chamber method. Just like the school books, you find that the 4 chambers are being displayed, in which I'll be able to see the cardiomyopathy, or there can be a dilatation, or there is a restriction with the distension of the left atrium. So the differential diagnosis. Apart from that, there can be deposition of some material such as iron, hemochromatosis. These can be diagnosed by using a pulse Prussian blue stain. Again, region-wise or disease-wise. So this is the left atrium in which I am finding a large ball-like structure protruding. It is pedunculated usually, causing a ball valve action. More than that, it will be causing a shearing force and damaging the walls of the atrium. The left atrial myxoma. As I mentioned earlier, the questions can be asked like this. In a case of autopsy of the heart, it can be region-wise. Left atrium, aorta, etc. Lesion-wise, myocardial infarction, vegetations, etc. Disease-wise, rheumatic heart disease. Manifestation-wise, where do you get a hypertension and so on. Differential diagnosis-wise, as we had seen in cardiomyopathy. Complication-wise, the mural thrombus and other things, aneurysm of the ventricle. So these are the various patterns in which the questions can be asked. But take it from me, you read the text, you listen to my classes, go to R.A.T.S, the answer will be fluent from within you. Types of prosthetic valves, no proper names. There are a lot of proper names given in the references. But please remember there can be porcine, bovine, cadaveric, allograft. These are the prosthetic valves that are available. And what is the complication of them? There can be a rejection. There can be a disseminated intravascular coagulation. Sometimes there can be a infection around the valve. This is called a ring abscess. This will lead to displacement of the valve leaflet, and this is called dehiscence of the valve. These are some complications which you people should remember. Sudden cardiac death is one. It can be because of anomalies, obstruction, floppy valve, conduction system, or very rarely because of mesothelioma. These are all not my list. This is the entire list that has been taken from Ludwig, summarized and presented to you in as brief a manner as possible. And this is a beautiful quote that I like and I always mention. The dead are teaching the living. And this is the author of it, Lars Kepler. This is one saying that is affixed in the museum of one of the medical college, PIMS in Pondicherry. I would like those students to kindly go back and correct me if I am wrong. Thank you one and all. I hope you have benefited by both these. These are of paramount importance, and definitely this video will be saving you a lot of time, getting you a lot of marks.